Peace be upon you all. My name is Iman Gazban, cardiac anesthesiologist at KMC Mecca. I am blessed to introduce this interesting case to you. And I'd like to start with an appetizer question. Did you see a post-CABG bleeding patient explored for anesthesia reason before? Let's go to our patient procedure and event. Our patient is 49 years old, 95 kilograms, diabetic patient with ejection fraction 45%, underwent an eventual CABG 3 grafts with post-protamine oozing, received 6 platelets and 2 gram fibrinogen, endorsed to CSICU on noradrenaline, 0.03 and insulin infusion. The endorsement ABG revealed lactate 1.4, blood sugar 161, hemoglobin 9.5, and ECT 107. The event in this case is exploration due to bleeding in CSICU 6 hours after endorsement. And the interesting in this case is the surgical findings. As this video shows, this video taken from surgeon perspective with the head direction up and leg direction down, and there is a bleeding from a circular opening where suction applied. And when we refer it to anatomy, figuring out that the bleeding coming from the right internal jugular vein while going to join the left innominate vein. Another video taken from anesthesia side with the head direction down and the leg direction up, showing the surgeon while taking sutures high in the neck to close such circular opening. And this is image. Let us revise what are the parts of the CVB kit. Starting from the injection needle, introducing needle, dilator, wire, and the catheter. And let's think about the possible causes. It may be either from central line insertion or from the first sternal wire. In our case, the right internal jugular vein may be expected to be at a deeper plane to be injured by a sternal wire. And also, if the right internal jugular vein was injured by wire, the opening may not be circular in shape and it may be slit-like opening. On the other hand, it may come from central line insertion, either from dilator most likely, or from needle, wire, or the catheter itself. And searching for possible risk factors, including inadequate experience in ultrasound guidance, advancement of the tip of the needle without visualization on the ultrasound screen, and advancing the dilator for long distance in the neck, which may cause injury to distal vessels or cardiac structures. How to prevent this? Prefer to use higher position in the neck of the needle better than the lower one. And the tip of the needle must be visualized in ultrasound screen. So if no tip seen, no advancement. And ensure the smooth passage of the guide wire without any resistance. And avoid pushing the dilator too much in the vein. It's only for skin and subcutaneous tissue. And while pushing the dilator, hold the guide wire to avoid injury from wire manipulation. Use bedside ultrasound to confirm catheter location and monitor for complication. Monitor for complication and management of bleeding to prevent further severe outcomes. Here is an educational case study demonstrating of central line catheterization using ultrasound guidance and real-time confirmation of placement via echocardiography and saline injection tests. Here is the right interjugular vein and right common carotid artery and the needle coming from up towards the vein, making tinting of the vein wall, popping, and finally needle tip inside the vein. And this is demonstrates best needle tip visualization. On the other hand, on the second video, we just seeing the shadow of the needle in the tissue, and in this video, no tip visualization. Another case, her videos taken by Dr. Amir Abu Dhikri, courtesy of him. The videos was for a 5 years old female child for CVB insertion in OR under ultrasound guidance using handheld device to confirm the correct placement. The probe was in the subcostal area and the video showing the liver and the right atrium under the liver with saline injection in the central line showing bubbles in the right atrium. Another case, 1 year infant for CVB insertion in OR. Also, his videos taken by Dr. Amir Abu Dhikri, showing here the liver with the atrium under the liver and the guide wire in the right atrium. Finally, from ASA practice guidelines for central venous access 2020, which revealed that observational studies demonstrates that the transthoracic ultrasound can confirm the residence of the guide wire and indicates that the transthoracic ultrasound can confirm the wire position. And thanks.